Welcome, everyone. I am absolutely thrilled to have you here for today's explainer because we are tackling a massive, incredibly critical topic. We're going to put on our clinical hats and walk through a rigorous step-by-step breakdown of one of the most pressing medical emergencies in human health. So grab your notebooks, get comfortable, and let's unravel the intricate anatomy, the underlying mechanisms, and the life-saving treatments of a stroke. 13.7 million. Just let that number sink in for a second. That is the staggering global incidence of new strokes every single year, according to the Global Burden of Disease data. Think about the sheer scale of that. It's not just a statistic on a page. It represents individuals, families, and entirely overwhelmed healthcare systems worldwide. It instantly sets the stage and establishes just how unbelievably high the stakes are for the pathology we're examining today. And to bring this even closer to home, this quote puts it into a terrifyingly rapid perspective. Every 40 seconds, someone has a stroke in the USA. Literally, by the time we finish this brief explainer, over a dozen people will have suffered a cerebrovascular event. It's a medical emergency that is happening rapidly all around us, and because of that, understanding exactly how it works isn't just an academic exercise. It's absolutely vital. Okay, let's quickly look at our syllabus for today. We'll start with 1, defining cerebrovascular accidents. Then 2, categorizing stroke subtypes. 3, mechanisms of ischemia. 4, hemorrhagic stroke pathophysiology. And finally, 5, time is brain, acute treatment. Starting off with section 1, defining cerebrovascular accidents. Before we can successfully treat or even categorize a disease, we have to rely on strict clinical definitions. According to the World Health Organization, a stroke, or cerebrovascular accident, is a rapidly developing clinical syndrome of focal or global disturbance of cerebral function lasting more than 24 hours with a vascular origin. Now, if you're taking notes, the crucial detail to circle right now is that more than 24 hours marker. That duration is the clinical key to diagnosing a true completed stroke. Now, contrast that with our next definition, a transient ischemic attack, or TIA. This is a focal neurological deficit lasting less than 24 hours, classically actually under 1 hour, with complete resolution and no infarction seen on an MRI. But make no mistake here, while the symptoms might resolve quickly, a TIA is a massive, screaming red flag. It's a true medical emergency because a patient faces a 10 to 15% risk of a full stroke within the following 90 days. Moving right along to section 2, categorizing stroke subtypes. All right, now that we have our definitions locked in, let's break down the 2 main branches of stroke pathology. What's really fascinating here is how we can visually differentiate between a blockage and a rupture. Notice how the ischemic stroke is driven entirely by a clot, either thrombotic or embolic, creating this starved zone of damaged tissue. This accounts for a staggering 87% of all strokes. Conversely, the hemorrhagic stroke, which accounts for the remaining 13%, is caused by a ruptured vessel physically flooding the brain space. This leads to a hematoma and severe perilesional edema. So, how do doctors actually tell these two apart in a chaotic emergency room setting? Well, both present with a sudden onset, although a hemorrhagic stroke might feature a severe, so-called thunderclap headache. But the crucial diagnostic pivot here, it's the CT scan. An ischemic stroke will actually often show a completely normal CT scan if it's done under 6 hours from onset. A hemorrhagic stroke, on the other hand, will immediately show up as hyperdense, meaning bright white blood on that scan. And that immediate visual confirmation dictates absolutely everything that follows. Which brings us to section 3, mechanisms of ischemia. Let's dive down to the cellular level to explore exactly how brain tissue begins to fail when it's starved of oxygen. Normal cerebral blood flow is sitting right around 50 milliliters per 100 grams of tissue per minute. Watch what happens as that flow drops. When it falls below 20, EEG silencing occurs, and the penumbra begins. This penumbra is absolutely critical. It's a zone of tissue that is starved and non-functioning, but structurally intact and, most importantly, potentially salvageable. But if flow drops below 10 to 15, we get electrical failure, and the irreversible infarction core begins. Below 10, ion pumps fail entirely, leading to absolute cell death. Okay, this is where things get really intense. Let's walk through this brutal ischemic cascade step by step. Step 1 is energy failure. Without blood flow, ATP drops and the cells depolarize. This triggers step 2, glutamate excitotoxicity, where massive amounts of glutamate are released. This overactivates NMDA receptors, essentially causing a lethal chemical overload in the brain, which of course opens the floodgates for step 3, calcium overload. This massive calcium influx activates destructive proteases and lipases that literally digest the cell from the inside out. This inevitably leads to step 4, cell death, expanding that irreversible infarction core. It is a terrifying, microscopic domino effect taking place in mere minutes.
Now for Section 4, hemorrhagic stroke pathophysiology.
We've just seen the devastating effects of starvation, right? Now, let's shift gears to the minority of strokes where the mechanism is driven by excess blood and pressure rather than a lack of oxygen. The mechanics here are devastatingly physical. Intracerebral hemorrhage, or ICH, is most commonly, about 60% of the time, caused by chronic hypertension. High blood pressure physically alters the walls of small penetrating arteries through a scarring process called lipohalienosis, making them brittle until they literally rupture into the brain, causing a mass effect that crushes adjacent tissue. On the flip side, subarachnoid hemorrhage, or SAH, is 85% caused by the rupture of saccular berry aneurysms. This floods the subarachnoid space, instantly spiking intracranial pressure and risking delayed ischemia.
And finally, Section 5, time is brain, acute treatment. Now we connect this microscopic pathophysiology directly to time-critical, life-saving clinical interventions. If there is literally one single fact you take away from today, make it this. 1.9 million neurons, 14 billion synapses, and 12 kilometers of myelinated fibers are lost every single minute. That is the harsh reality of an acute ischemic stroke. It perfectly drives home the time is brain motif we use in medicine. Every single 10-minute delay in faster treatment costs a patient approximately 1 week of healthy life. The speed of our response directly dictates the patient's future.
Because of that incredible cellular damage, doctors are racing against strict biological clocks. From symptom onset to 3 hours is the gold standard window to administer IVTPA. That's the powerful clot-busting drug, Alteplase. That window can sometimes be extended to 4.5 hours for certain eligible patients. But if there's a large vessel occlusion, doctors now have an incredible window of up to 24 hours to go in physically with a catheter and pull the clot out, a game-changing procedure known as mechanical thrombectomy. But, before we even get to those high-tech interventions, basic physiology is what saves the penumbra. This is the ABC of initial stabilization: airway, breathing, circulation. But I want you to pay special attention to temperature and head positioning. We treat fever aggressively because every single degree increase in temperature worsens the outcome for that starving brain tissue. And we keep the patient's head completely flat for the first 24 hours in most ischemic strokes. Why? Gravity. Keeping the head flat maximizes cerebral perfusion pressure, essentially pushing whatever tiny trickle of blood is left right into that dying penumbra tissue. Well, we have covered a lot of ground today. We've gone from massive global statistics all the way down to microscopic ion pump failures and finally straight to the emergency room clock. It's a brilliant, if utterly terrifying, cascade of events. So I'll leave you with this final thought. With 1.9 million neurons lost every single minute, how quickly can you recognize the mechanism of a stroke? Because at the end of the day, understanding this disease isn't just about accumulating clinical knowledge, it is about recognizing the race against time. Thank you so much for joining me on this explainer. Keep asking those great questions, and I will see you next.